Hello, everyone, and welcome to the second live event organized as a part of McGill World Restart a Heart 2024 campaign. We're a global initiative that aims to empower individuals to respond to cardiac arrest. For those of you who may not know us, we're a student-led, faculty-supported global initiative that started within the Faculty of Medicine and Health Sciences here at McGill University. Our main goal is to inspire individuals to act and give them the skills that's necessary to respond to cardiac arrest. We believe this to be an important public health investment and perhaps the most impactful approach in reducing morbidity and mortality that is associated with cardiac arrests. My name is Mona Sharafi, and I'm a second-year medical student here at McGill University and a logistics co-lead for the McGill World Restart a Heart 2024 campaign.
My name is Cédric Enzi. I'm a second-year dental student at McGill University, and I'm also a logistics co-lead of the McGill World Restart a Heart campaign 2024. We have the privilege of being joined by leaders in pediatric cardiac arrest care and outcomes. Our guests today have made tremendous effort to improve pediatric cardiac resuscitation outcome for all through their clinical experience and scientific research. We will learn about the multiple inequalities in pediatric cardiac arrest care and how to bridge the gap to attain equity in care. To set the tone, I would like to first share an exceptional video created by members of our student and steering committee during the 2020 campaign on how to respond to cardiac arrest. So in the next 60 seconds, I invite you to learn how to save a life.
In Canada alone, every 12 minutes, someone suffers from a cardiac arrest. If you don't do anything, they are going to die. In the next 60 seconds, we're going to teach you how to save a life.
If you see someone lying unconscious, the first thing you want to do is check if they're responsive. If they are not responsive and not breathing or breathing abnormally, they are likely suffering from a cardiac arrest.
Call 911, let them know that someone suffered from a cardiac arrest, send someone to find an AD if there's one nearby, and then start chest compressions.
For chest compressions, find the center of the chest, put your dominant hand down, interlock your fingers, and push hard and push fast.
Using an AED is really easy. You just apply the pads, turn on the machine, and follow the voice instruction. The machine will analyze the rhythm and tell you if a shock is recommended.
I would now like to introduce our guests for today. We're lucky to have Dr. Mayem Naeem, a pediatric intensivist at the Children's Hospital of Philadelphia. Dr. Naeem is the Associate Chief of Research in the Division of Cardiac Critical Care Medicine at Children's Hospital of Philadelphia. She completed a fellowship in pediatric critical care medicine and in pediatric cardiac intensive care. Dr. Naeem also has a master's in clinical science and epidemiology. So welcome, Dr. Naeem. Finally, Dr. Cody Gathers, a pediatric cardiology fellow at Children's Hospital of Philadelphia and a postdoctoral research fellow working to mitigate racial, ethnic, and socioeconomic disparities in pediatric cardiac arrest. Dr. Gathers also completed a Master of Science in Health Policy at the University of Pennsylvania. Welcome.
Cedric, you're muted.
I'm very sorry. So I was saying thank you for joining. So for a lot of people, including professionals, it could be very difficult to understand cardiac arrest, especially in pediatric populations. So could you please explain the mechanism of cardiac arrest in healthy and sick children? And also, what's the difference between adult cardiac arrest and pediatric cardiac arrest? Thank you.
Yeah, thank you, Mona and Cedric, for having us here. This is awesome, and it's great to see the work that you all are doing to bring this issue to light. I'll just start by saying that the mechanisms for cardiac arrest that occur out of the hospital are generally broken down into two big categories. It's what we call hypoxic causes, or causes with the lungs not receiving a lot of oxygen, or cardiac causes. And within the hypoxic causes, those are typically things that are due to kids having drowning incidents in pools, or what we call sudden infant death syndrome, that mainly occurs in infants as well. Children can have very bad illnesses that cause their lungs to be really sick, and they can have a cardiac arrest at home too if they're sick enough as well. And then when it gets to the cardiac causes, within that category, there's two big categories that we call sort of arrhythmogenic causes. So it's not a problem with the electrical activity in the heart itself, whether that's, the electrical activity is, it's just not allowing the heart to sync properly, and it causes the heart to go into an arrhythmia and beat abnormally, or what we call cardiomyopathy. So that can be that the heart is too big and it's not able to get enough blood out to the rest of the body, or the heart is too thin and it's not able to generate the strength to pump the blood out or relax enough to get enough blood in either. And so that's really how it looks like in children. And anytime a kid has a cardiac arrest outside of the hospital, we do our due diligence to really get to the bottom of the story, figure out what's going on and what happened, and rule out all of these major causes pretty quickly. And then that differs from adults, because adults primarily do have cardiac causes, mainly arrhythmogenic causes. That's due to sort of long-term and long-standing heart disease, although there are other causes as well that do occur in adults, but it's primarily the major cause.
And then I think I would just like to highlight that cardiac arrest is pretty rare in the overall pediatric population, especially compared to the adult population. So the incidence of cardiac arrest in general in adults is much higher than in children. However, there are some children, especially those of infant age, who have a high incidence of cardiac arrest. And as Dr. Gathers highlighted, the main thing that we think about, and the big difference between children and adults is that in children, the most common mechanism of cardiac arrest is a respiratory or a hypoxic event, whereas in adults, the most common cause of a cardiac arrest is a cardiac event. Whether it's a child or an adult, what you do in response to that, especially in the out-of-hospital setting, is exactly the same. So your video highlighted exactly how we would train bystanders for pediatric CPR in addition to what we would do for adult cardiac arrest.
Thank you very much for your responses. That really clarifies the mechanism of cardiac arrest in children. But it makes us wonder, how does cardiorespiratory reanimation exactly differ in children, like in terms of the breaths, the compressions, and the shocks?
So that's a great question, Mona, and this has really been a topic of research for me. And so, again, we're going to focus our discussion in the out-of-hospital setting for today, and for the child that collapses outside the hospital or is found outside the hospital. And till a couple of years ago, it wasn't clear whether children benefited from CPR. The majority of children, about 50% of children who have an out-of-hospital cardiac arrest, are infants, and very often these children have a cardiac arrest that happens at home and is really a unwitnessed event. And so it was very unclear whether these infants or younger children benefited from bystander efforts like chest compressions and the use of an AED. So one of the first things that I looked at, and again, this was I would say this was in 2013, we did a study using a large out-of-hospital cardiac arrest registry in the United States known as the CARES database. And our specific goal in the study was to see whether bystander CPR was even an effective intervention for children who had an out-of-hospital cardiac arrest. And we did an age stratified analysis. And one of the other things that we were very interested in looking at was that, as you can see, we train, as you can see even from your video, that the way we train is hands only or compression only CPR. And this was something that since 2005 had been very widely disseminated in the United States as the way to do bystander CPR. So we wanted to see if this intervention had impacted children who very specifically, as I mentioned, the most common cause of their cardiac arrest is hypoxic or respiratory in nature. So we did this study using the cardiac arrest registry to enhance survival. We looked at all children aged from birth to 18 years of age, and we had some very interesting findings. The first was that about half of children who have an out-of-hospital cardiac arrest receive bystander CPR, and that was very encouraging. The majority of these children receive compression-only CPR when they have an out-of-hospital cardiac arrest by a bystander. So that messaging of doing hands-only CPR has permeated in the community, and children are receiving bystander CPR, and the majority of them are receiving hands-only CPR. And what we did find was that in infants, those children less than a year of age, performing hands-only CPR in terms of outcome was very similar to no bystander CPR at all. So their outcomes were poor when compared to CPR with rescue breathing. And then if we looked at children older than a year of age, those children benefited both from compression-only CPR and conventional CPR. That conventional CPR is CPR with rescue breaths. In both age groups, or in all age groups, conventional CPR is better, but compression-only CPR is effective in survival to hospital discharge and neurologically favorable survival in children over an age of a year of age. So I hope that that's helpful in answering your question. In children of, and to summarize, in children of all age groups, conventional CPR, which is CPR with rescue breaths, is associated with survival to hospital discharge. However, in babies, that is children less than a year of age or infants, doing compression-only CPR, that's CPR without rescue breaths, that's similar to doing no bystander CPR at all, and not associated with good survival. Cody, you're muted.
Sorry about that. No, it's a excellent point, and I think all of that just perfectly highlights what we try to teach out in the community, at least when we're giving CPR education to parents and families as well. And so ultimately, I think it's something that we'll continue to keep looking at and trying to ensure that while we're teaching hands-only CPR, we're at least educating the public about the importance of rescue breathing as well. But it's often a fine line to balance when you're trying to cram so much into one educational session.
Thank you so much for your responses. Now that we understand the basics of pediatric cardiac arrest and the differences that exist, we can move on to today's topic, which is inequities in pediatric cardiac arrest outcomes. But before we dive into the disparities that exists in pediatric cardiac arrest care, I would like each of you to please explain what got you interested in this topic.
Yeah, thanks for that. I think it's super important to at least set that context a little bit. And for me personally, I've always just been interested not only in critical care, but community engagement. It's just been sort of a core part of who I am, not only as a physician, but as a person as well. And so I'd always been looking for something to tie those two things together throughout my education and clinical training. For me, that actually happened very serendipitously through Dr. Name. I think when I first got to CHOP as a first-year Piggy Fellow, she was one of the first meetings I ever had in terms of research and mentorship. And we talked a lot about a variety of different ideas. And I think one of her key studies had just been published a year prior that she'll talk about a little bit later in this podcast. And so I was really attracted to the possibility of working with her. And so we put together a series of ideas, and I would say I launched into a couple different projects, but then when my master's came around, I really wanted to tap back into this community engagement piece and wanted to really understand the mechanisms behind why we were seeing a lot of the inequities that we were seeing in out-of-hospital cardiac arrest. So And cardiac arrest itself really presented this unique opportunity to not only engage the community from a research perspective, but also a community advocacy and policy perspective. And then as a critical care fellow, I would often see children arriving into the emergency department after having a cardiac arrest, and just seeing anecdotally firsthand some of the disparate outcomes that we were seeing, and some of the disparities in who was actually arriving to CHOP. It was quite striking to see. So all of those things taken together, I was really pulled into how can we make this better? What are the things that we need to be doing to engage the community? And what can I add to this topic? And it's been really humbling over the years to really dig into it and get involved.
So I'll just start by saying that I am inspired by Cody every day and his level of community engagement. For me, it was kind of interesting how I came into this field. And again, I really started off by being very interested in understanding bystander CPR and who gets it, which children get it, which children don't get it. And what's going on. And the main interest was initially bystander CPR. And when we first started looking at this again, at a cohort between 2013 and 2015, in the very first study that we published on this in JAMA Pediatrics, what we found was very interesting. So when we were looking at differences between children who received bystander CPR versus those who didn't, one of the main differences or reasons to not receive bystander CPR was a child's race or ethnicity. And this was very confusing to me because the majority of people who provide bystander CPR to children are parents or caregivers. And so I did not understand why this racial inequity existed, because for me, it was, if a parent is providing bystander CPR, why would a parent not provide bystander CPR to their child? Why does this form of racial inequity exist? And so this is really where I became interested in this. And I had a real lack of understanding why this was happening. And I started looking a little bit more into why this existed. And I think we're going to talk about this a little bit later, but that's really where my interest in this topic started.
Thank you very much for your responses. We're really glad that you're tackling this very important issue.
Yes, so Dr. Naheem, talking about the same article. So you are the lead author of race, ethnicity, and neighborhood characteristics are associated with bystander cardiopulmonary resuscitation in pediatric out-of-hospital cardiac arrest in the United States, a study from CARES. So can you share with us now a little more about this study?
Yes. So as I mentioned, we were very interested in trying to figure out why certain children of certain races were not receiving bystander CPR. And one way of looking at this was to look at where these children came from, what neighborhoods they lived in, and really what what is underlying this. And what we looked at was that we looked at neighborhoods in the United States where these cardiac arrests occurred. And what we tried to do was, using our census data in the United States, we characterized these neighborhoods by certain socioeconomic characteristics. So each neighborhood received a score of between 0 to 4. And this was really based on characteristics that included the median household income in that neighborhood, the level of high school education, the employment level of in that neighborhood, as well as the percentage of Black residents within that neighborhood. And we came up with a score, and this score was used to figure out what's going on in these neighborhoods where kids aren't receiving bystander or Are they receiving bystander CPR? Are they not receiving bystander CPR? And what we found was that in a neighborhood with an index score of 0, so an index score of 0 is an affluent neighborhood that has a high level of education and none of the kind of risk factors that I talked about. A white child in that neighborhood had about a 60% incidence of receiving bystander CPR. So 60%, that's pretty high. However, if there was a Black child in a neighborhood with an index score of 4, so in the neighborhood with all the risk factors that I talked about, the incidence of receiving bystander CPR was almost half of that. So those children were half as likely to receive bystander CPR compared to a white child. Even if a Black child lived in that affluent neighborhood, they were less likely to receive bystander CPR. So in each one of our categories, a Black child was less likely to receive bystander CPR compared to a white child. But in the neighborhoods, those most highest risk neighborhoods, just think a Black child in that neighborhood was half as likely to receive bystander CPR. So it's not really, it is a racial inequity, but it's also a form of almost systemic racism that we see within within many communities where there's a lack of education, there is a lack of knowledge about bystander CPR. So the reason why parents aren't doing CPR to their kids is because they don't know how to do it, or they haven't been trained, or they don't know how to recognize that their child is in cardiac arrest. And so I think that this was really enlightening for me. And after this, a lot of people who have been looking at inequities really look at these, what we call social determinants of health. And I think that this was, for us in the out of hospital cardiac arrest research world, this basically showed us that the reason why these inequities exist is because of lack of education, lack of knowledge, the environment that the child lives in, and Cody will talk about next steps, but I think that this was very, as I said, enlightening for us.
Thank you very much, Dr. Naeem. It's very unfortunate to hear that such inequities exist. Dr. Gathers, you presented socio-demographic disparities in incidence and survival for pediatric out-of-hospital cardiac arrest in the United States, which was a report from the Cardiac Arrest Registry to Enhance Survival at the American Heart Association meeting in 2023. Can you please share with us your findings?
Thanks. We conducted this study because, while the sort of epidemiology and the differences in conventional versus non-conventional CPR had been defined and some outcomes had been defined. And then Dr. Naeem had really looked at a lot of the disparities that she just discussed. We really didn't know whether or not the incidence, whether or not disparities in the incidence had actually existed. And so we wanted to take a look at this and dive a little bit deeper, because while you can think about it as there could be disparities in survival based off of who gets CPR and who gets an AED and those sorts of things. But really, when you look at the incidence, that's the actual event of a cardiac arrest occurring. And so why would there be disparities in that? And so when we took a look in the same registry using the same sort of socioeconomic score that was discussed, we saw that the general incidence for all children was approximately 8 per 100,000 children. And so that really mirrors what we had seen in a lot of other studies that have been published previously. But then when you look at the differences in incidence by race or ethnicity, the incidence of out-of-hospital cardiac arrest among Black children was approximately 16 per 100,000, while the incidence among white and Hispanic children was roughly 3 per 100,000. And so very striking differences in the actual event of cardiac arrest occurring. And then when you look at socioeconomic status, children who come from sort of, less affluent neighborhoods with less resources and who are, at least in our database and by our definition, less educated and poverty-stricken neighborhoods, the incidence is much higher in those neighborhoods as well, roughly 12 per 100,000 children, versus in the more affluent neighborhoods, it's about 4 per 100,000 children. And so you may ask yourself, why is that? What's occurring? And it all sort of gets down to the etiology of the cardiac arrest. So earlier in the podcast, we talked about, you know, hypoxic versus cardiac causes, and the hypoxic causes in children are mainly attributed to SIDS and drowning. And so when you actually dig deeper into the literature, you'll see that other people in the pediatrics world have really defined a lot of these disparities that do occur in SIDS and do occur in drowning. And all of that is really just goes back to community advocacy and community engagement and educating folks on these things. I think if you even take a walk around some places in Philadelphia where there's public pools, pools are supposed to be gated and supposed to have a lot of resources and with lifeguards, but that may differ depending on where you're living within the city. And so that is something that we're even seeing firsthand, that we just re-demonstrated with a national database as well. And then also in the study, if you look at sort of the age breakdown, infants have a much higher incidence of cardiac arrest in general, but then when you break it down within each age group by race or ethnicity, Black infants have a much higher incidence of cardiac arrest as compared to white and Hispanic infants. It's roughly 40 per 100,000 children, as compared to white infants, it's roughly 10 per 100,000 infants. And so again, it's about 4 times that. And that, we believe, we can't prove it in this database because we don't have the exact cause of the cardiac arrest. But we believe that that's probably attributed to sudden infant death. And then one of the last striking things that we saw was that among adolescents, and so this is getting more into the what we think of as cardiomyopathy or arrhythmias causing the cardiac arrest, there's still a slightly higher incidence of this occurring in Black children as well, as compared to white and Hispanic children. And so, and when you actually look at studies that have looked at disparities in the incidence of sudden cardiac death, what we call, which is, when we say sudden cardiac death, we basically mean, is it arrhythmogenic or is it a cardiomyopathy? Those studies have also re-demonstrated disparities across SCS and race and ethnicity as well. So, we'll talk a little bit more about what we're trying to do in the community to capture that. But those are just things that we're seeing, and I presented that at the AHA last year, and that study is currently under review at a journal, and hopefully will be published soon. And then we can use that as a springboard to really advocate for more resources in the community.
Thank you both for your explanations. That was very, very good to hear. Before becoming a dental student, I was working as an anesthesia assistant. So I was very close to pediatric patients with cardiac arrest, and even in ICU. So it's really, really nice to understand the situation outside of the hospital, because we don't usually get to see that. So now that we understand the problem better, how can we bridge the gap and address the inequities and improve the outcomes for all children? Dr. Gathers.
Yeah, it's such a great question. I often think of this sort of bridging the gap and bridging the outcomes is, what can we do along the chain of survival to within cardiac arrests to improve each outcome. So the AHA has a chain of survival that includes primary prevention of cardiac arrests, CPR and AED administration, high quality CPR and activation of medical services, and then ultimately recovery. And so I sort of think in my brain, okay, within each link, just assume that there are disparities within each link, and how do we tackle each disparity within each link? So within the prevention phase of it all, this goes back to educating parents and family members on the causes of cardiac arrest in children, and actually trying to bridge those gaps in who we're capturing and those who are at risk for cardiac arrest. So oftentimes, even as a pediatric resident, I would educate first-time parents and not first-time parents on the risk of sudden infant death syndrome, and many parents had no idea what that was. And so educating them on that and safe sleep habits was all very paramount to what we were doing in the clinics, and also is now paramount to what we're doing out in the community in terms of primary prevention and education, and advocating for gated swimming pools, which should be a standard across all of America, but unfortunately it's just not. And then and lastly, we are always actively working with an organization here called Youth Heart Watch that is now conducting screening events in these high-risk communities to screen children not only for cardiomyopathy, but arrhythmogenic causes of cardiac arrest, like long QT syndrome. And so these are things that we are actively doing in the community that are hopefully going to make a difference, and other people throughout the United States are doing these things as well. And so at these events, children will come, they'll get a full physical exam by a doctor at CHOP. If that exam or the history is concerning, they will then get a full cardiac echocardiogram by a cardiologist at CHOP, and then get an EKG as well by a CHOP that is read by a CHOP cardiologist. And so I think that is an excellent initiative that we're continuing to work to do. And then Dr. Nam and I have really worked out in the community to enhance CPR education through CHOP's Center for Health Equity. We are always tagging along with their events and also conducting events throughout the community to teach parents and families about the importance of CPR and providing CPR lessons to a variety of people. And through these initiatives and training sessions, we've trained probably over 450 to 500 parents and families at this point. And so I'm super excited to see where all this goes in the future as well. But I'll let Dr. Nam talk a little bit more too, because I could talk all day about it.
I think, Dr. Gathers has spoken very nicely about like what we're doing kind of on the grassroots level. But I think the other thing is what to do kind of on a national level, or, what can we do to prevent inequities and make sure everyone gets trained on a national level. So the video you showed at the beginning is a very nice kind of grounding thing for us. But what can we do in terms of advocacy? So the American Heart Association and others have basically advocated for there to be CPR training as a mandate or as a law in every state in the United States. And so far, I think at the state level, there are 39 states in which it is mandated that every high school student graduate with a CPR education. So that's a CPR mandate that many have worked on, and this is a mandate that's implemented on a state level. And then the other is there are also certain states that have AED mandates. And this is not only for, this is for AEDs in schools and in other public places. So I think that there's a lot that needs to be done to bridge inequities for all by what can be done in terms of legislation, state laws, and even federal laws to prevent, to make sure that we implement things across in all communities. And but what happens with a lot of these mandates is that there may be a mandate, but how is it implemented or enacted? And so those are some things that are very, very important. But I think hopefully some of our work really highlighting that these racial and neighborhood disparities exist would help people who are trying to implement these mandates know that they may be, for example, if there's a school in a neighborhood that has that is an at-risk neighborhood, if there's limited resources, maybe one should put more money or more effort into those neighborhoods versus other neighborhoods where they may already have AED or CPR training. So I think that efforts need to be made both at a national level and at a statewide level to not only prevent cardiac arrest, but when it occurs, to have plans for CPR in schools and train train our high school students, and then also make sure that AEDs are available where they're needed.
Perfect. Thank you for your solutions and interventions. So it's very reassuring to see that there are solutions, and more importantly, that there are people like the two of you working to mitigate racial and social disparities within the hospital and outside of the hospital, like we said. So before we conclude, I would like to hear from you. What are the next steps in terms of research and projects?
So from my standpoint, I am very interested in mentoring others in this work. And currently, we have work ongoing again with the cardiac arrest registry to enhance survival, really looking at other disparities that we may see in cardiac arrest. So currently looking a little into gender disparities. So hopefully you'll see that work from us coming up soon.
Interesting.
From my perspective, it's more just trying to figure out why we're seeing the disparities we're seeing in CPR and AED utilization outside the hospital in some of these higher risk neighborhoods and across different racial and ethnic groups. And my work right now is really using a primary survey to talk with parents or ask parents about their perceptions of CPR and their level of education with CPR and those sorts of things. And so that data is actively being collected across a variety of CHOP clinics in Philadelphia and different community sites. And I'll use that data to really hone in on some of the disparities that we see within Philadelphia and potentially encourage other institutions to utilize a similar survey to really figure out the underlying mechanisms so that we can target some of these higher risk communities.
Thank you very much for your responses. It's very exciting to hear about your current work and what the results of these research will be. So we've reached the end of this exciting live event. Dr. Mariam Naeem and Dr. Cody Gathers, thank you both so much for your efforts in promoting equity, diversity, and inclusion in pediatric cardiac arrest care. And most importantly, thank you very much for your time.
You're welcome. Thanks for inviting us. This
Thank
was
you.
great. Great session.